to be a morphologically also it is malignant. But this is an MR spectroscopy. We zoom and you have to look at one magic area, that is 3.2 ppm. If the choline is elevated, then we call this tumor as malignant. So again, it is very important. This area number is 3.22. Similarly, in prostate, we get normal BPH or normal prostatic area. You get prominent citrate peak. If the area shows a peak at 3.2, this is 3 and this is 3.2, if you see a tall choline, that is malignancy. So most of the areas in spectroscopy, we look only the choline at 3.22. So you have to remember this area. Now come to basic MR spectroscopy. We do either a single voxel or a multi-voxel. This is an example of multi-voxel. A single voxel we place usually 2 into 2 centimeter size voxel of a region of interest. We do either press or steam. That are all the types of single voxel spectroscopy. All that multi-voxel are CSI, that is a chemical shift imaging, either 2D or 3D. So you write single voxel spectroscopy, press, steam, and the multi-voxel chemical shift imaging 2D, 3D. And what is the difference between these two is that in voxel we can get the biochemical components of only that area. In case of multi-voxel, we can get the biochemical component within the lesion as well as within the normal area, so that we can compare how much particular metabolite is increased or decreased. Indications, you know that focal diseases, to differentiate benign lesion from malignant lesion, whether it is in primary or metastasis, whether it is a tumor, abscess, or tumor or some other, it is whether there is a radiation necrosis, to differentiate some other lesions. So that are all the focal lesions, and diffuse conditions like temporal lobe epilepsy, some inborn errors of metabolism, mitochondrial disease, again can be diagnosed with spectroscopy. Then you should know the normal spectrum. This is the short T MR spectroscopy done at 7 Tesla MR, just to show the metabolite map. At 1.33, normally you won't get any lactate peak. It may be seen only in the early neonate as a normal spectrum. If you get lactate, then it indicates an anaerobic metabolism. So usually you won't get any lipid peak at 1.3. Another metabolite we get at 1.3 is the lipid peak. So lipid is also, when there is a cell is broken, then you get this lipid at 1.3. So you won't get any peak at this area. Then this is a very important peak. This is the tallest peak, that is N-acetyl aspartate, and this is a neuronal marker. So any disease affect the brain will cause decrease in the NAE. And only one condition where there is an NAE is increased is Canavan's disease. So you should remember this spectrum. Then at 2.3 or 2.4 you get glutamate and glutamine peaks. These are all neurotransmitters. This may be altered in case of hepatic diseases, because these are all synthesized in the liver. So you have to remember that. Then this is a normal metabolite peak at 3. 3 is the creatinine. It may be phosphocreatine, and another second peak of the creatinine is at 3.8. But usually we see only at 3, and this is taken as standard because creatine won't affect by any disease process. So this is standard as reference to compare any metabolite peaks. So you have to remember this creatine peak. And at 3.2, I told this is the choline peak. Whenever there is any choline is present in the cell membrane, whenever there is an increased cell turnover, you get increased choline. So when choline is increased, then you have to suspect a malignant disease. Whenever there is any disease process affecting the brain, where there is a destruction, you get mild increase in choline. So don't call that all that choline elevation or malignant. Even demyelination will cause elevated choline. The significant numbers that matters, that I will show in next slide. Then you have 3.5 some peaks taurine, myelocytes, it all there. So these are all the important compounds. I will just show the few examples. And this is the example of how this lipid and lactate, because both will appear at 1.3, how to differentiate that. Another technique other than single voxel, multi-voxel, another one is that we do 3 sets of MR spectroscopy based on the TE. We'll do short TE imaging, intermediate TE and a long TE. So you should remember that. If you are doing short TE, both lipid and lactate will be an upstroke, so it will go above. And if you see an inverted peak at 1.144 or intermediate TE, then it is lactate. So in that way we can differentiate. At 288 again lactate will be going upright, whereas the lipid will not be seen here at 288. The best thing is that you have to do intermediate TE. If it is going down, it is lactate. If it is upright, then it is lipid. In that way, we can differentiate lactate and lipid. Lipid will have a shoulder on the left side, whereas lactate is a doublet. In that way, also you can differentiate. These are all the ways to differentiate. Again, I want to show this is a tumor of medulloblastoma. You can see arising from the roof of the fourth ventricle. You can see there is a CSF cleft on the floor of the fourth ventricle, and the multivoxel spectroscopy. Within that multivoxel spectroscopy, we know that which area to biopsy, which area shows higher choline strength, which area is necrotic, and the peritumoral extension also be nicely seen. And this is a case of glioma. The spectroscopy, single oxygen spectroscopy, shows a very tall elevated choline. It is not a simple elevation above the creatinine. It is 2 times or 3 times more, and there is an increase in the lactate level. If you see a lactate level, if you see, then it will be usually seen in grade 3 or grade 4. Only in grade 3, grade 4 you get lipid lactate peaks, and the spectroscopy also tells the creatinine, choline creatinine ratio is more than 3, or this patient to prove to be a high-grade glioma. Another one to differentiate high-grade glioma versus metastasis is that the gliomas are infiltrating along the white matter. So even if it is normal-looking white matter, that will show increased choline level in case of glioma, whereas metastasis won't grow. It is an extra-neuronal tumor, so it will expand. So there is within the glial tissue, so you won't get any choline elevation outside the tumor. In that way, you can see outside the tumor. In case of metastasis, you won't get any choline elevation. Whereas in case of glioma, because it is extending along the white matter, you get a choline elevation. Here is one example, post radiation patient that shows very tall lipid lactate. This is at 1.3. Again, I told if you see a peak at 1.3, then it may be a lipid or lactate. That indicates necrosis. Another one, we have to see that there is a small amount of choline is also there. So this is also a combination, mixture of a residual tumor with radiation. It is not purely a radiation necrosis, because choline is elevated when compared to the creatinine. So there is a mixture tumor of recurrent tumor and necrosis. And this is a case, obviously we know that it is an extra-axial tumor, it is a meningioma. Because it is an extra-axial tumor, extra-neuronal tumor, we don't get any NAA peak. If you don't see NAA peak, then you have to consider it is non-neuronal tumor like meningioma or metastasis. Metastasis is coming from other areas, and you get a very tall peak. So this is a case of meningioma. You get a similar invert at 1.3 that we call it as an alanine peak. So these are all the MR spectroscopy findings. And another one, what are the areas we should avoid spectroscopy in hemorrhage? If you put spectroscopy within the hemorrhage, then you won't get any spectra. And if you are putting on the CSF, you may not get a good spectra, and you have to avoid near the surfaces so that a lot of fat contamination may not cover. So these are all the areas you have to be very careful to do spectroscopy. Other diseases can be diagnosed with MR spectroscopy, include brain abscess. This is obviously a diffusion restricting lesion here. You can see that there is a lipid peak, there is a lactate peak. And you can see at 1.9 there is an acetoacetate, and you can may see some other peaks like succinate at 2.3. So these are all tell this is an brain abscess. Some specific metabolites tell this is in brain abscess. You can diffusion again, the typical light bulb cells, it is in brain abscess. This is a case, there are some multiple lesions in the brain. You can see that there is a multiple lesion here. Even in the temporal lobe also you can see that it is T2 dark, and this flare also it is dark. Diffusion also it is dark, and it shows ring enhancement. It is to be a T2 dark lesion intraparenchymal. Most probably it is a tuberculoma, and which shows intense enhancement is tuberculoma. If it is an lymphoma, then we expect a solid full enhancement of this entire nodule. And MR spectroscopy again confirms there is a tall lipid peak, again confirms it is a tuberculoma. So lipid peak is seen in case of tuberculoma. All other features are also favoring tuberculous lesion. So it is MR spectroscopy is very supportive in this patient. And this is a very obvious case of neurocystic psychosis, Scolex inside. Sometimes we may have a doubt like this. There is a very large cyst. We don't know where. This is an unusual size of a neurocystic psychosis. The patient also had a neurocystic psychosis also elsewhere. Here also you can see that. And we did MR spectroscopy that shows very tall lactate and a succinate at 2.4. 2.4 you get a succinate. If this succinate is more than lactate, then we consider usually hydatid cyst. If it is less than the lactate, then we consider it's a neurocystic psychosis. Both are parasitic cyst, so you have to consider these two changes will occur in both cysts, NCC as well as hydatid cyst. So these are all the patterns we have seen, and we will see some other examples like mitochondrial disease. Again, we get typical lactate peak. And another one is this is a patient with diffuse cerebral atrophy. This is just opposite of the leukodystrophy. Here you get only the gray matter atrophy. Gray matter neurodegeneration is manifested by brain atrophy, and the MR spectroscopy shows decreased NAA. This is actually not an increased choline. This is just a decreased NAA, and this turned out to be a neuronal serial hypophysis. Or you write gray matter neurodegeneration. This is an example. This is a patient with 1 year old. What is this? What is this? 1 year old subcortical white matter is involved. Cannabis, very good. At 1 year old, you may not get this much NAA. NAA is actually lower. At 2 years only, we get adult pattern. Before 1 year, the NAA is the smallest peak. After 2 years only, we will get an adult pattern. 1 year old, if you get an adult pattern, that tells that's an increased NAA. This is a Camel's disease. And this is a patient with some skin ichthyosis, you see that, and some non-specific white matter changes. And again, MR spectroscopy shows what is this peak at 1.3, which is upright lipid. If it is going down, then it is lactate. And this is a lipid peak that confirms it is a Jogerel-Larsen syndrome. So you should know that this is a fatty aldehyde dehydrogenase deficiency with the deposition of fatty acid. That is why there is an increased lipid in MR spectroscopy. One final slide on this, and this is a normal spectroscopy, and this patient presented with developmental delay. This is an MR spectroscopy, and this is for normal for comparison. Any finding? MRI brain is absolutely normal. They have sent for developmental delay. This is the spectroscopy. It is like just like reading the ECG. So this is, I have given some comparison also. Very good. So you know that the creatine is missing. In the normal patients, creatine peak is there. This turned out to be a creatine deficiency. Yeah. So this is a creatine deficiency. There are 4 enzymes, 3 enzymes deficiency is described. So you have to be very careful. Even in normal developmental delay patients, we do MR spectroscopy. Other metabolite peaks, you should remember that in medulloblastoma we get taurine, in central neurocytoma we get glycine, and in meningioma we get alanine. Coming to the second topic is the CSF flow imaging. That you know that daily circulation in the brain is around 140 to 150 ml of CSF in the brain, and there is a contiguous protection and excretion of the CSF. You know that all are produced in the choroid plexus of the ventricle and then subsequently absorbed along the epidural veins or along the arachnoid granulations. You know the physiology. I'm not going to that physiology. And the technique that you have to write is that this is done with a sequence called phase contrast MR imaging. So So this is the phase contrast image probably you have come across, that you may see this phase image in SWA. Similarly, you may see this imaging in the cardiac. You may get in phase contrast angio. So all are similar sequences. So these are all called CSF, the phase contrast CSF flow imaging. That important thing that in that we have to see is the velocity bend. In the monitor you have to see the bend. If you are keeping the looking for a shunt malfunction, then we have to keep the bend between 2 to 5 centimeter 5 second. Then only you get a flow across the CSF shunt. If you are looking at a normal CSF flow, then we have to keep 5 to centimeter per second. If in case of normal pressure hydrocephalus, we have to keep more than 10. Then only you will get a good CSF flow. So this is very important. You should remember second parameter other than the phase contrast is the velocity encoding. One is the magnitude image, another one is the phase image. So white means there is a systole, there is a flow across the aqueduct, fourth ventricle and extending down. So this indicates systole of the CSF flow, and diastole indicates pressure the CSF across the cerebral aqueduct. How to plan? This is you have to plan perpendicular to the aqueduct. Aqueduct is oriented like this, so you have to plan exactly perpendicular that so that you will get exact value. If you are doing something like this, then you may not get a true velocity of the CSF flow. So this is very important. One is bend, second one is perpendicular to the flow. So again, once you have done, you get a curve like this. If this is in velocity, you get the peak velocity around. Normally you get 5. If you see around 4, 10, 8, and then we is most probably is a case of normal pressure hydrocephalus. This is the systole, that is we told it is a downward flow, and the upward flow is the diastole. So these are all the waves. We get systole and diastole, we get a flow. Normally each CSF flow may takes 800 milliseconds each CSF cycle, and we get all that measurements. Like if you do the CSF flow, then we get peak systolic velocity, we get a stroke volume. We can calculate the stroke volume across the aqueduct. If it is more than 42 microliter, and then in the case of normal pressure hydrocephalus, then the patient will do better with the shunt surgery. Again, this is to show how we do the planning. This is perpendicular to the aqueduct, so there is no flow. So that indicates some obstruction or tumor or some. So here is an example. Here you can see there is a rectal glioma or a pineal region mass here. There is no flow across the aqueduct. So we tried CSF flow across that, and there is no flow noted in the CSF imaging. This is tended to be in rectal glioma. Other common indication is normal pressure hydrocephalus. You know that obviously the imaging findings, and you can get the accentuated CSF flow, and the peak systolic velocity will be also more. So based on that, we know that is a normal pressure hydrocephalus. In this patient, it is the stroke volume is more than 51 microliter, and this patient will respond to the shunt surgery. Then another one is that this is the area of the normal third ventriculostomy. We want to know whether there is flow across the third ventriculostomy, and we have done a CSF flow that shows flow across the third ventriculostomy. So we know that there is still it is patent. Another one, we want to know the flow across the shunt, so that we have to plan perpendicular to the shunt tube. If it is passing like this, then we have to plan like this, so that we can know there is any flow within the shunt tube. The technique is very important, and for the evaluation, we keep the velocity encoding is 2 to 5. For the normal pressure, it is hydrocephalus, we keep 15, around 15 to 20 also. Other indications is cherry malformation. In the cherry malformation, we do sagittal imaging. We may not quantify, we just want to see qualitatively whether there is any flow across the foramen magnum. If it is completely obstructed, then this patient may be an ideal candidate to do foramen magnum decompression and the tonsillectomy. Because there is no flow, so this ultimately land up with the syrinx formation. So we have to look for any flow. Normal patients, you get a good flow in the anterior and the posterior at the foramen magnum level, and and this patient is an ideal candidate surgery. The third topic is the perfusion imaging. In perfusion imaging, we do three ways. One is that without giving contrast, what we call as arterial spin labeling. That software is available that we can do in every patient. And second one is that we do with contrast. We do a T1 or T2 star weighted. There are two types of post contrast perfusion. So you have to write these three. And indications are mostly tumors, to differentiate various types of tumors and the stroke. So these are all the indications. Other perfusion techniques include CT perfusion. CT perfusion again exactly quantify the amount. So what is the difference between the T2 star weighted post contrast perfusion and the T1 post contrast is that we measure absolute measurements in case of T1 post contrast. In the T2 star weighted imaging, we measure regional relative cerebral blood flow, relative cerebral blood volume, and mean transit time, where we measure the K trans in case of T1 post contrast perfusion imaging. And the tumor grade will be assessed in case of T2 star imaging. The vascular epithelial growth factor proliferation is better assessed with the T1 post contrast. So again, we are assessing because it is T2, we are assessing darkening. In case of T1, we are looking for the enhancement, and we usually do within a minute, less than a minute in case of T2 star weighted imaging. We are acquiring the first pass of the contrast, so it is sub-second in case of T2 star imaging, whereas in T1 weighted imaging, we do 2 to 25 seconds. So the effect may be very small in T2 star imaging and a large in T1 weighted images. So these are all the difference in T2 star and T1 weighted images. So the T2 star we do 60 dynamic acquisition and saline flush, and we get the images. So these are all the images we get with the perfusion. How to analyze after acquiring the perfusion? We have to put region of interest. This we have kept along the white matter. You can see that we kept this is the white matter. This is the first of the contrast. This is the cerebral blood flow volume of that normal white matter, and this is we kept in the thalamus. So this is the corresponding to the gray matter. You get the normal first pass cerebral volume of that area. And we kept one region of interest in the tumor, and you know that this is the cerebral blood volume of that area. We call relative cerebral blood flow. Whatever the area under the curve corresponds to the cerebral blood volume. If it is increased, then we call it as most probably a tumor. If it is so much increased, then we call high grade tumor. So that is the use of that. In case of T1 weighted post contrast, we do that with surrounding edema, necrotic area that shows heterogeneous enhancement, and the perfusion of the normal area. This is for the normal area, the cerebral blood flow is like this. In the case of this tumor area, that shows the cerebral blood volume is maybe 3 times or 4 times, and it's to prove to be a glioblastoma multiforme. So this is a like in spectroscopy. It is one another method that will again confirms the diagnosis as well as to grade tumor. Again, another supportive. Another tumor here in the location of the choroid plexus. The lesion is T2 dark and shows intense enhancement. When we did the contrast, that shows increased cerebral blood flow compared to the normal area. And one other thing that we show that this is not reaching the baseline. Of the post contrast, whatever is not reaching, it is leaking through the venous. There is a lot of arteriovenous shunting there. That is why it is not reaching the baseline. One of the tumors that we have is the meningioma that shows a lot of that is a lot of age. So this turned out to be a meningioma. Another tumor that this is the location periventricular or in the thalamic lesion that shows nodular enhancement. On perfusion, there is no significant increase or mild increase in the cerebral blood flow volume. What do you think this is? It's a tumor which shows normal perfusion or mild increase, and you can see that even on the post when it reaches, no, it is overshoots the baseline. This is the typical lymphoma. This is a typical lymphoma. So again, perfusion is very useful to characterize it's a high grade, low grade, or lymphoma. Another example that this is a patient, 12 years old child presented with acute stroke. They thought this may be a tumor, and MR conventional shows diffusion brightness on the periphery. Contrast shows incomplete open ring, which is to we know obviously it is a TB factor demyelination. Even the surgeon don't want you want to operate. Then we did perfusion that shows a hyperperfusion. If it is in red color, then it is hyperperfusion. This is an hyperperfusion. So obviously, it is not a tumor. So and then subsequently, this patient completely recovered. So again, in cases of doubtful cases, you can use perfusion imaging to differentiate tumor or non-tumor, or to differentiate high grade versus low grade. Very common indication for doing perfusion is that is the stroke. We know that diffusion is one way to assess the infarcted tissue. We don't know other areas at risk, so we do a perfusion that shows a large defect. Perfusion studies shows large perfusion defect, but only this much is infarcted. So this patient is an ideal candidate. There is a mismatch more than 20% of the infarcted. So this candidate, this patient may be an ideal candidate for post thrombolysis. Similarly, this patient pre thrombolysis and the post thrombolysis, and there is a good amount of reperfusion. And if there is a no mismatch between the diffusion and the perfusion, there is no need to thrombolysis, because all the perfusion defect are infarcted, so there is no need to do thrombolysis. So these are the ways that you can do interpretation of the stroke imaging. Then arterial spin labeling, I told we use the arterial water as the intrinsic tracer instead of injecting contrast. So we don't use any IV contrast to do this arterial spin labeling. And we get good, the problem is that it may not be a good spatial resolution. We can quantify with this arterial spin labeling. Again, similar to the other perfusion, we can interpret. Final one word about the CT perfusion. Again, CT perfusion, we can quantify exact measurement like CT MR perfusion. Again, absolute quantification is possible with the CT perfusion. The final topic is the diffusion weighted MR sequence. We use bipolar gradient adjacent to the 180-degree pulse. We get diffusion weighted imaging. You know that diffusion, the bright area corresponds to diffusion restriction. What we believe is that in normal, all the molecules will move equal in all directions. That is isotrophic diffusion, but it is not true. In case of white matter, the water molecules move in particular direction. They call it as an anisotropy. To measure the anisotropy, they introduce diffusion tensor imaging. So instead of 3 sides, they use more than 6 directions. They apply this gradients more than 6 directions, so that we get diffusion tensor imaging. So the difference between the conventional diffusion imaging, that we assume all the movements of the protons are isotrophic, but in the real sense it is anisotrophic, that you have to know the difference. Then in the diffusion we apply only 3 directions, whereas in case of DTI we apply the gradient more than 6 directions. These are all the technical difference. We may acquire in 24, 48 or 128 slice, 128 directions, then it takes more time. Then after acquiring the image, we get this much color-coded FA map. The blue color tells that the corticospinal tract is going above downwards, and the red color indicates the fibers going across from right to left. Green color tells antero-posterior. So that and we get the value that most commonly used value. Fractional anisotropy. Fractional anisotropy, you can assume they are giving the value from 0 to 1. 1 means in ideal setup like a white matter tract, if all the protons are moving in one direction, you get the value of FA of 1. Whereas in case of CSF, all the protons will move in equally in all directions. It will not move to any particular directions. So you expect a value of 0. Ideally, we may not get 0. we get 0.1 to 0.2 in case of CSF, and we may get normally around 0.7 in case of corpus callosum, where all the white matter tracts are going in one direction. So, but the normal value is 0 to 1. Idea on real value we get 0.1 to 0.7. So these are all the, this is tractography. If you put region of interest on the corpus callosum, then you get the entire fibers which is traversing along this course of the RY will be on the computer calculates and gives this tract. What are the use? How to interpret this DTI is that there are four ways that you can interpret. First, whether it is causing deviation, whether there is a tumor or any lesion that causes deviation of this white matter tract. Second one is that it is infiltrated or destroyed or just it is swollen. So in this patient actually there is destruction of the white matter tract. So when you compare with the opposite corticospinal tract on this side, that lesion is infiltrating this lesion. Whereas another example to show this is in case of epidermoid, you can see that the color, because it is multiple fibers are there, you can get color flow within the lesions. Another examples of DTI, that this patient presented with dysplasia, aphasia, and we noted there is an hemorrhage in the left superior temporal and the middle temporal gyrus. Then we did the DTI. In the normal side, you can see this is an arcuate fasciculus that connects the Broca's areas to the Wernicke's area. You show the normal white matter tracts, and in case of this the hemorrhagic area, you can see some destruction of the fibers. That is why this patient had aphasia. So these are all the things we can get from the DTI. So these are all the examples of the specimen images, and this is the we have get within 1.5 Tesla. This one I have did with 3 Tesla. So even the finer tracts can be seen within MRI. These are all the examples how displaces the tract. I showed some destruction. In this patient, the lesion just displaces the tract, so that the surgeon plans to do surgery can avoid this tract. Instead of going from here, he can go from the laterally and remove this tumor. Other areas of indication includes in spine. This is the normal tractography, and this is a case of extensive myelitis where you can see the white matter tracts are see the changes in the white matter tract. Another patient with traumatic paraplegia. This is post follow-up. This is a normal tract in another normal patients, whereas in case of this patient there is near complete restriction, and that is why we can say that this patient may not improve with any other treatment. So to conclude, MR spectroscopy, again, you know that basic thing that we may quantify the small biochemical components of brain tissue. We can measure the small changes in the brain. Then the CSF flow, we study the base contrast image. The thing is that you have to plan perpendicular and you have to keep appropriate length. Under perfusion, we studied the basic non-contrast arterial spin listening and the post-contrast T1 as well as T2 star weighted imaging. And finally, DTI, where we apply more than 6 directions the gradient, and we get all the measure. Mainly we measure the anisotropy and uses whether it is displacing or destroying the lesions. I thank you for your kind attention. Thank you very much.